It is an absolute honor to introduce tonight's speaker, Al Stammers. He is the VP of Quality and Outcomes Research with SpecialtyCare. I've had the pleasure of working with Al over the last few years. We've done a lot of different research papers together and many of these webinars, and we are very excited to have him present tonight.
Thank you so much, Shannon. And it is indeed a privilege to go ahead and discuss this. And as Bridget said earlier, this is something we all have a tremendous amount of experience with, and it really came to a head over the last 2 years. But what we're seeing right now, the Surgeon General has identified this as what we call, or what he's calling, a silent epidemic. And this epidemic is not patient-driven; it's actually occurring to the providers, and that's all of us. Burnout, work-related anxiety, occupational exhaustion, these are all made their way into the lexicon of the health industry. And most people are describing this right now as a burnout syndrome. And we're going to go over not only some of the causes and the numbers, but also some of the ways that we can alleviate or mitigate this. Just 2 things to discuss over the next 25 minutes or so. We're going to look at stress. We'll look at a little bit of the history, but we want to really emphasize what's going on with all of us today. We're going to look at nurses, surgeons, perfusionists, and very briefly at anesthesiologists. And most of the focus, of course, is going to be on the perfusion profession. And then, of course, look at ways that we can ameliorate this. You know, stress is really not a term that is all that old. I mean, it was first described in the healthcare industry and actually industry in general only 80 years ago by the physiologist Hans Selye. And he was looking at hormonal influences, the neuroendocrine responses that occur with stress. And he's credited with the comment, "It's not stress that kills us, it's how we react to it," which I think we all would affirm to. Each year, the Gallup poll is published, and they look at stress across the entire world. In 2019, the New York Times published on this. And what the Gallup poll uses is called a negative experience index. And if you look on the horizontal axis, over the 12 years that they've been reporting, we see that the negative experience is actually going up every year, and meaning that there's more stress related to what's going on, not only in our work environments, but also in our home and social environments. And in America, we see that 55% of all people who were polled in this, over 150,000 individuals from 140 countries, reported stress, and that's at the highest level in most countries. In fact, if you look at this color graphic, the lighter the color, the less people who are reporting stress on a daily basis, with 14 being the lowest, which is occurring in Taiwan, and the highest at 54 is in Chad. So the darker green, the more stress is being reported. And it's particularly prominent in individuals under 50 years of age, those having a low income, and those who follow politics. You know, welcome to America a week ago. How many of us were so happy to see the end to the political advertisements that were occurring? Well, where is the stress least and where is it the most? CareerCast publishes a job-related survey. The last one was in 2019, rating 200 professions. The number 1 and number 2 related jobs in regards to the overall ranking were data scientist and statistician. In fact, these are huge fields right now that are just growing by leaps and bounds. And you can see in the center here that stress is very low in both of those, and employment opportunities are great. Well, what about the healthcare industry? Physician assistants and physicians fall right in the middle of these categories, ranked at 102 and 103 collectively. And you can see why they're so poorly ranked is the work environment and then the level of stress. If we look at the 10 highest ranked jobs, which are the least stressful, the most enjoyable to work for, you can see them shown on the left-hand side right here. And one thing that pops out of all of these is probably the majority of them don't have really a lot of direct patient contact. And then if you look at the worst jobs, emergency medical technician is almost at the bottom. There's 200 jobs here, and that's ranked at 197. And we'll talk about that in just a second. And 3 of these are nurses. Nurses are actually worse than physician and physician assistant, coming in at number 122. Well, what do we know? What are we finding out? If you look at going back 30 years or more, we can see that the publications that are occurring on a yearly basis are really peaking. So if you search on stress and healthcare workers in 2021, the last time we had complete data, were just under 1,600 publications. And then if you look at burnout in healthcare workers, we can see that almost 3,500 publications were in PubMed last year that had these search terms in them. Well, let's start with just a definition. What is burnout? Burnout is a negative work-related state of mind where the effectiveness of the individual to do their job in a manner that they're used to performing is decreased. There's a lot of dysfunctional behaviors that occur and just generally a feeling of malaise. In the medical field, Freudenberger, who is an American psychologist, described burnout as the consequences of severe or prolonged stress and anxiety experienced by all of us. And I would imagine all the participants on the webinar, every one of us has experienced stress in a manner that probably was higher than we've had most of our careers during the last 3 years. I think when Shannon was kind enough to introduce me, I'm an emeritus perfusionist. I haven't been in an operating room in 7 years. And, there is light at the end of the tunnel because it has been actually an enjoyable time to continue to work in perfusion. And I mentioned this on many of our webinars. I really admire, the perfusionists who've gone through the last several years. They're on my hero list for what everybody's gone through. And I'm also married to an operating room nurse who's actually going in for an emergency this evening. So I feel what everybody's doing. So what did the National Academy of Medicine several years ago talked about? Well, what do you see with burnout? We mentioned emotional exhaustion, a depersonalization, and we're going to talk about conflict in just a minute here. A sense that you're not accomplishing anything, productivity decline. And if you have patient direct care, patients see this too. They pick up very well. All of us who have been on the receiving end of healthcare, it's very easy to tell if our healthcare provider is not really attuned to what's going on. But look at this, increased medical errors. And we're going to talk about this when we talk about nurses in just a minute. This is really scary. And again, all of us would state that once we're in a stressful environment, once we're fatigued, once we've gone through the long work days that we normally are experiencing, we know that there's a higher tendency for medical error. But what does that translate into? This relatively recent publication looked at the cost, and this is in billions of dollars for burnout by physicians. And the odds ratio for actual turnover show that this makes up the majority of the cost. Over $4 billion are in turnover. And we all know, we'll talk about the Great Resignation in just a moment. We know that this is occurring on a daily basis throughout all of our specializations, and especially in perfusion. So let's look at some of the providers themselves and see what the data tells us. Surgeons, 53% national burnout, report burnout, while the national average for all healthcare providers is 28%. So you'll see this on the next several slides. Importantly, over 6% have a suicidal ideation, and which is very scary. And I'm sure this is similar, although not reported in several other specialties. I bet you it's pretty similar in perfusion and nursing and anesthesia as well. And a quarter of these surgeons sought psychological care. In anesthesiologists, 50% report burnout, but cardiac anesthesiologists tend to be more stressed than non-cardiac. And most of the data that's out there is on nursing. This is a really high turnover profession, a lot of people changing jobs, not just going per diem, but actually looking for changing out of their individual specialty. We see this occurring more and more again. 45% at burnout, and these are relatively older data. These are going back 10 and 15 years. So I bet if you did this right now, repeated these surveys, this would be higher. And we do have some data to show in just a second. And 62% of the nurses report making errors. And a lot of that is related to the patient to nurse ratio. And that, of course, mostly is found in ICU environments. And each additional patient increases the chance of death and a failure to rescue by 7%, 15% increase in job dissatisfaction, and 23% increase in burnout. I don't know if you've all seen the recent data that was published in the anesthesia literature that said they looked at anesthesiologists who were monitoring one room, anesthesiologists monitoring 2, 3, and 4. And the higher the number of rooms an anesthesiologist was monitoring with nurse anesthetists, the higher the death rate, the higher the accident rate that they were seeing in those situations. So really, really scary. But let's focus now for the majority of the rest of the presentation on perfusion. Those who've been in the field for 20, 30 years, maybe even 40 years, remember Paul Friday. Dr. Friday was a psychologist from Shadyside and now part of UPMC, I believe, who used to contract with AMSEC to provide psychological services. He spoke at a lot of our meetings back in the early 80s. And if you saw some of his presentations, they were really scary. But anyway, his first presentation, publication, was Inject in 1985, and he looked at nurses, surgeons, and perfusionists, and he wanted to understand more what went into the stress-related environment that all three of those specialties were working in. He said the causes were, we were always in a close proximity to death. This is, basically, lecturing to the choir here. We all know that every one of our jobs is so critical that most people would not choose to do it as a career. It takes a special person to be a perfusionist. We work very long hours, whether you're in an academic environment or a community environment. Decreasing rewards. Remember, this is 1985. This was before the salaries of perfusionists skyrocketed. This is when I got involved in the field. And then, interestingly, public prominence had a factor as well. He identified three characteristics that have to be in perfect harmony in order for an individual to have a low stressful relationship and a low stressful character. Bluster, he described as being where somebody would move against a person. Pleasantness is where we move towards a person. And self-isolate is where we just don't want to be around people. So these were characteristics he looked for in his survey. And he found that nurses were best at meeting all of these characteristics. They had a great balance between all three, and they were most well balanced in the team. But unfortunately, perfusionists and surgeons, they really moved against people, and they didn't want people around them most. It's interesting to see the reasons why, which we'll talk about in just a second. But they really were very, very similar. The results for perfusionists and surgeons were almost identical. A few years later, he did another survey looking specifically at perfusionists, when he calls these technologists and medical technologists, these are perfusionists he's referring to, not our normal medical technologist. He described the psychometric snapshot of a perfusionist as being a highly trained and very pressured individual. And the results he had shown that over a 5-year time period where managed care, if you remember back in the early 90s, managed care, HMO, PPOs, they were just really gaining their strength in the medical environment, mainly to reduce cost. And he said that this caused perfusionists to actually move more against people, to be more blustery and self-isolated, and then less likely to move towards them. So very interesting phenomena that were occurring in the late 1980s and early 1990s. So what about perfusionists and what are the publications? All of these are old. There hasn't been a survey on perfusion publication that has occurred in over a decade. But if we look at what people reported, 18 to 60% perfusionists reporting a high level of burnout. Remember, this is pre-COVID. This is before the perfusion shortage. This is really predates a lot of the factors that led to our increased stress. Stress was induced by conflict, call duties, hour work, and caseload, but conflict had the greatest effect. Everybody is nodding their head right now. The job we do is so stressful and hard to accomplish. But then when you have conflict on top of that, whether it's with our workers, with a nursing group or with surgeons, physicians, we all know the horrible stories that we heard actually out of Indianapolis that occurred that made the front page headlines of a perfusionist who was traumatized by a surgeon almost 15 years ago. And so, what did he find? What was found with these particular studies? There was an inverse relationship with burnout and job satisfaction. So the more you were satisfied with the job, the less you were likely to be burned out. But as dissatisfaction in the job increases, turnover increased. Income negatively impacts job satisfaction. This is really critical because a recent survey on perfusion opportunities for employment had shown that perfusionists were actually less satisfied if they were seeking jobs that paid more money, usually that it came with additional hours of work as well, than if they had more reasonable salaries but a better work-life balance. And then there's this gender issue, which we're going to talk about. So the causes of burnout, again, a lot of this is relatively recent, some a little older. You had those that were occurring at home. It'd be very nice if we could separate home from our work environment, but it's very difficult to do. It's almost impossible. So the home instigators were individuals who were younger aged, having children at home. All the parents or grandparents can attest to this. And then work-home conflicts. If you had something that started at home and then made its way to work, or started at work, made its way home. And the work instigators, increasing medical information, electronic medical records, new technologies, patient expectations. Nobody wants to go into an environment and feel that their outcome is going to be compromised. Fear of being sued, specialization, how much you're on call, and then compensation based specifically on billing, really in the physician realm more than perfusion. I mentioned earlier the Great Resignation. We're in the middle of it right now. COVID induced it. Why it occurred, and this was data from the Pew Research Center that was recently published. If you had to be vaccinated and you were, against vaccination, this really was traumatizing for individuals. Wage stagnation, inflationary rate now approaching 8.5%. Limited opportunities for career advancement. Most perfusion practices are based on 3 people practice. And if your chief, if your ladder is from a staff perfusionist to a chief perfusionist, and your chief perfusionist is 45 years of age and wants to continue there to retirement, the chances of getting a promotion there are probably not very good. Hostile work environments, lack of benefits, and these actually seem to be declining with the increased economic challenges in healthcare. We're going to see these actually probably eroding at a higher rate. Clinician burnout, the 2021 class research survey looked at individuals who are likely to leave versus likely to stay. And if they're completely burned out, 60% of the individuals are leaving. Symptoms of burnout, they just can't get over it. It's not something that was getting benefit. And then you can see stress and no burnout have much lower chances of turnover. This is more recent data. The Great Resignation, 300,000 healthcare providers dropped out of the workforce just last year. I mean, we all see this. In fact, in some of the local areas here in northeastern Pennsylvania, the overtime pay for at least nurses is 2 to 3 times what it used to be, with individuals pouring multiple shifts and making a tremendous amount of income. But of course, with a higher amount of burnout and stress occurring. A very recent poll that looking at 2025 data that was published by the Elsevier Health Group, publishing a report called Clinician of the Future, looking at 3,000 doctors and nurses, said that 47% of healthcare workers plan to leave by 2025. That is remarkable. That's half of the practitioners who are in place right now. Very, very scary. So how do we fix it? We'll shift now gears and spend the rest of the time talking about how can we reduce stress and reduce burnout. This Larson cartoon, probably oversimplifies what the treatment should be for all of these ailments here with looking at equine medicine. So clearly there's multifactorial steps that have to be undertaken. I mentioned that the Surgeon General report, the federal government has identified workplace well-being as one of the top priorities facing them in the very near future. The Affordable Care Act tried to address this, but it didn't do a good job. So now it's really been emphasized by the federal government, and that means it's going to pour into a reimbursement at the local hospital and healthcare facility level. So they describe 2 essential human needs: safety and security. So what we all want is protection from harm. But really, this is a 5 tooled answer to promoting health in the workplace. Community connection is extremely important. Work-life harmony. How many of us feel that this could be one of the major challenges with being less stressed at work and at home? Mattering at work, wanting to feel that we're being appropriately recognized for the job we do. Perfusion has always been challenged because many hospitals don't even know they have perfusion personnel there. So to get recognized, if we're looking just at a surgeon or an anesthetist to recognize this, it probably isn't significant. We know that our nursing colleagues and surgeons and physicians, they get recognition very frequently. What's our growth opportunity? We're going to talk about that in just a second. And then primarily, this is all focused on having a voice with what the environment is that we work in, and having an equitable workplace. This is not necessarily a stress-related publication. This just occurred a couple of weeks ago in Time magazine, and it talked about being ambitious. And why do we seek ambition, or how is ambition good? There's the extrinsic. We want more authority, perhaps gaining a position of leadership, and then thinking that that's going to lead to wealth and status. Unfortunately, when we're seeking these, the unintended consequences are depression and anxiety. And the way to stay healthy, this particular publication said 5 areas that we should look at. Prioritizing your relationships, which we'll talk about just in a second. Focusing on the task, not looking at the rewards. I've already mentioned, and I think everybody would agree that if we're looking for an economic reward as our primary outcome measure for success, we're probably not going to be as happy as if we chose a different focus. Practice gratitude. Just being kind and thankful is something that how many see be kind placards out on lawns throughout the area. So we know that's important. Staying away from the monetization of what we're doing, and then striving for growth. This is a critical area, and this is one that I've really struggled with and gaining insight in, and that's looking at the generation gap. Today's generation, X and Y generations, and even millennials who are going to be soon to follow, that's making up the majority of what's our healthcare workers today. But people in leadership positions are people like myself, gray-haired baby boomers, who perhaps are within the last 5 to 10 decades of their work environments. And we have a completely different idea in regards to the goals and what should be occurring. Thank goodness, the younger generation, the X and Ys and millennials, they want a more balanced work balance. And you'll hear people, old guys like myself and others, grumpily saying, boy, I remember, back in the beginning of the dawn of age where I used to work 500 hours a week and, blah, blah, blah. Well, that probably isn't true. And I think, those changing attitudes are going to be more healthy. One of the big problems that are occurring today are electronic health records. And if you ask physicians and nurses, the amount of time they spend fixated with, doing charting is way above what they would normally do to provide clinical care. And this is a major area of dissatisfaction inducing stress. And you say, perfusionists are wiping their brows saying, oh, we don't have that. But we really do. If you look at the development and the how the technologies in heart-lung machines have evolved over the last just decade, if you had shown me this back in the early 80s when I was getting into perfusion and say, this is what you're going for, I don't know if I would have chose that career. This is all very intimidating. Perhaps, though, if you're a Generation X or Generation Y and you grew up with the higher technologies, it's something that is more stimulating. But that stress is still there. It's something to be considering. So what does the FDA did? Luckily, they've come out. They just approved the drug. It's called Peaceorty. The generic name is I don't give a fumab. And this is an injection that's given for medical burnout, and it's been proven to target C-suite peptides, as well as the electronic health record cascade. And those individuals who were treated said that after they were treated with it, they felt less likely to type at a keyboard with their back to the patient, nor did they want anymore to apply to law school, write a novel, or sell crafts on Etsy. So I obviously, tongue in cheek, this is all information for reducing stress that doesn't exist. These pills are not available, and something else has got to be done. Other stress inducers, legal matters. If you've ever been involved in a lawsuit, nobody starts their day, at least very, very, very few bad apples, going in and wanting to hurt somebody, but we all have that potential of making a medical error. And once you add long hours, excessive call, basically staff shortages, this actually all increases, yet the threat of having litigation, at least in North America, perhaps some of our colleagues from abroad who are on the call may want to comment on this. We know it's a real problem. Now let's spend just a couple of minutes going over gender inequities. And unfortunately, women are much more susceptible to stress, burnout, and hardships associated with clinical responsibilities than men. This was a large study of 30,000 surgeons with 5,000 women replying and 6,800 men. And the women respondents were younger than their male counterparts. They had lower rates of marriage, lower divorce rates, and lower number of children. But if you look at some of the scary reports, the scary data that came out of this report, is that child rearing slowed career enhancement. So women were less likely to start families if they were more career focused. And we know a number of individuals in very prominent positions in leadership today who are female cardiac surgeons and perhaps even perfusionists do suffer if they feel that their career, if they want to have children and they want to enhance their career by having kids. Conflict with partners' career. Women were more likely to feel conflicted with their partners than men. And then finally, experienced work-home conflict in the last 3 weeks. Women were much more likely to have these work-home conflicts than men were. Burnout rates were 4% higher in women than men, and depressive symptoms were about the same, depressive symptoms. So it's really scary. And this is really, I think, an extreme focus that the Surgeon General has also identified, not treating both genders equally, but looking at these conflicts that are related to basically sex. So what can we do to deconstruct burnout? It's really about building resilience. And if we look at the added reward at the top and the added stress, we can see income, benefits, prestige. These are all listed as an added benefit. Yet the stress is related to, as already discussed, call, scheduling and patient flow, performance, poor management. Leadership has been identified as one of the primary factors for stress, a lack of leadership. And that if we then look at what's going on from an inherent perspective, we know that once we are trying to find meaning and finding ways to heal, these are really things that we have to look inward towards. And then finally, a witness to suffering and monotony are all causes of what need to be addressed. So there's a nice Cochrane analysis. Now it's several years old right now, but they looked at a summary of systematic reviews and meta-analyses to go over what you can do to reduce stress. And they said there are 2 areas that we had to focus in on. One was the work-directed interventions. And as I mentioned just a minute ago, leadership is number 1. A lack of leadership, right on down from administration to the chief perfusionist, to the head of the OR nursing, to the chief surgeon. This is where the pinnacle of problems begin, and where hopefully challenges to improving the stress and reducing this in all of us can be focused at. As I mentioned, the clinician supervisor, interventions that enhance collaboration across groups. Remember silos. I worked at an institution once where the chief cardiac surgeon told me, when I asked, can we attend the reporting of medical errors and the grand rounds and these mortality conferences, he told me directly, the only time I'll be invited to one is if I screw up and make an error. So, that type of philosophy was really wrong. And, hopefully that's not something that you're experiencing. Peer support, that conflict resolution. If you don't have good peer support, individuals who are walking the walk and doing what we're doing, understanding what we're all going through. And as I just mentioned with gender, women have to, basically perform at a higher level at men just to reach the same level of performance. That's ridiculous. I mean, understanding these inequities need to be the focus of our interventions. Incentives and rewards. Remember, money is not an answer here. People have thrown a lot of money at bad situations only to make them worse. And then frequent dialogue. Person-directed intervention. So what can we do at the individual, not at the level of the hospital per se? Obviously, physical exercise, good eating, hobbies, family, friends, and colleagues. We're going to talk a little bit about that as we get towards the conclusion. Stress management techniques. Again, this goes right into the athletic healthiness. I was very fortunate over the latter part of my career where I was able to spend many years in the martial arts with my son. I used to sit and watch him when he was 6 and 7 years old. And then finally I said, if I'm going to sit here, I might as well get in there. So we spent 7 or 8 years together and really was very, very helpful. Yoga, my wife is a good yoga individual. This is really, really important. And then having realistic expectations, self-compassion, and a pursuit of I think we all suffer. We want to have, zero type of variations from what our performance will be. And that's trying to pursue perfection, but really we should just try to work as an excellent individuals. Family and friends. I mean, it's critical to surround yourself. There's so much research that talks about loneliness, especially in the elderly, but also in individuals, we're here in their second, third, fourth, and fifth decades of life, suffering from that, not having a strong environment. As we approach the holidays now with Thanksgiving and Christmas and Hanukkah and all the holidays coming up, we'll be around family. But what happens in January? We know the first 3 months of the deep winter, really, we see a lot of stressful environments taking hold and a lot of depression. Volunteerism, Bridget and Shannon and I were discussing earlier on the call before we started, how important it is to volunteer. And we see that in AMSAC, for example, in the American Academy, more and more individuals are throwing their hat in the ring to volunteer. And I think that's really important, not only in the professional societies, but outside of the home as well. What about animals? Much has been written up the effect of dog ownership and mental well-being. Dogs we know offer companionship. They reduce anxiety and loneliness. They increase self-esteem. Cats, not so much. But as those cat owners, and I happen to be one, they do bring us a lot of enjoyment. There's just not a lot of research that has shown that they are actually beneficial. And I'm sure a lot of people are groaning right now because, and I agree with them. I mean, cats are definitely solvents for reducing a stressful situation. What about other animals? If you're living on a farm, and having these animals around, we raised chickens for a number of years, and it was just wonderful, until they got picked off by predators one by one. So it's depressing to see them go. As I mentioned, dog ownership. These are studies. Kramer looked at a review of meta-analyses and said that if you had a dog, you had a lower risk of death over the long time. And Mubanga looked at individuals who had acute MIs, 1,800 individuals, and he found that if you had a dog, your risk of having an MI or a stroke reduced by almost 10% over 11 years. So really, really interesting. And some of the reasons that they thought this was occurring were increased activity, just moving around, and social interaction. How many people have taken their dog to a dog park and all of a sudden stroke up a conversation with other individuals, or just definitely a way to break the ice. Other distractions, and I would love to spend the next 20 minutes going over all of the people on the call here, what we're using as hobbies and what we do on the side. Shannon's dogs were barking earlier, which was just wonderful to hear them. But some of the things that we do, I think maybe some people know I have an 80-acre homestead here, and I love forestry. I love cutting trees, and I haven't bought a sawmill yet, but it's next on my budget, and so I'm always out in the woods if I have the opportunity. And another hobby of mine is I like restoring cars. This was a '57 Chevy I bought when I was in Nebraska. I did a frame-off restoration on it, and that's what it looked like when we were finally done after a few years. And just something that it was enjoyable. And my kids, when they were growing up at the time, they helped me a lot with a lot of the work on this. So let's summarize and conclude with what the Gallup poll has said are the ways to alleviate stress and to improve our overall health. The first thing is to like what you do each day and to be motivated to achieving your goals. The nice thing about perfusion is not an avocation, it was a vocation. Most of us, when we finally found it, whether you're a 22-year-old, I would think I was 30 when I graduated perfusion school. If you found it later in life or found it earlier, it absolutely is a wonderful profession to be in and very, very rewarding. Having supporting relationships, the social interactions, love in our life. I think we all can attest on time periods, perhaps when we ended a relationship with a significant other or lost a mom or a dad or heaven forbid, a child, how devastating that was at the time. Managing economic life to reduce stress and increase security. This doesn't mean just getting our 401ks and optimized and so that we could live stress-free when we retire, or getting outrageous salaries right now. It really is a balance, as we talked about before. Community, liking where you live. It's amazing what opportunities are available for perfusionists now in regards to living in a rural environment. As I mentioned, I live in a 80-acre homestead. I don't have a neighbor within a half mile, but I grew up just outside of New York City with 11 kids. So having that opportunity to be in the community now that I enjoy is been something that I strive for. But likewise, individuals living in San Francisco, New York, LA, Philly, all Indianapolis, all across the country, what great opportunities there are for so many things going on socially, education-wise, and of course, just having good hobbies. And then finally, having good enough health to enjoy and get the things done on a daily basis. I think that goes without saying, and it's something that we all strive to do. So with that, I want to thank you for your attention for this brief 30 minutes or so, and I look forward to the question and answer session and to moderation by Bridget and Shannon.
Thank you so much, Al, for that. You've gone over several key points and how we can just decrease our stress in life with physical activity and volunteering in your community. But let's just start with our first question this evening. This is from Daniel Rodriguez, and he says, not all can be a Navy SEAL, not all can be a perfusionist. Should we have better personality screening to communicate to a candidate what perfusion is really about?
Wow, that's a really great point, and I'm sure what Dan's talking about here is, last decade or so, once we hit the beginning of our shortage, is now we're getting huge number of individuals applying to every one of the perfusion education programs, and it'd be very interesting if a program director is on the call to comment in the Q&A session about what goes into their personality analysis. When I was a program director, I always looked at individuals. I took a liking, being from a city, I took a liking to farmers and ranchers being out in Nebraska, because it seemed like when those individuals came in, they were able not only to really technologically answer problems that they occur because they were used to baling twine and duct tape more than guys like me growing up in and around the city, but they just seemed to have a good work-life balance. Now, that is just one example. And I really can't say that goes into the success, because individuals who are coming out of urban areas are just as talented in doing things along those lines. But I agree that, looking at those personality traits, we shouldn't use a Navy boot camp, a SEAL boot camp, for example, to weed out individuals in perfusion. But we really should make sure that individuals who are coming in aren't coming in for the wrong attitudes, such as increased employment opportunities or economics.
Excellent, thank you.
All right. Next, we have, also from Daniel Rodriguez. He says that better staffing models provide a better work-life balance. Should corporations be obligated to balance staffing?
Yeah, great point. I mean, and he's Daniel, you're spot on. And it's been a real challenge across the entire industry, not only for like an outsourced perfusion provider. There are many of them throughout the country. SpecialtyCare is one. But you're right. I mean, having a work-life balance so that when you go in, you don't put in a lower number of individuals trying to save money, and then compromise those individuals' health and safety and well-being at the chance of earning money. I think every outsourced perfusion provider would state that if that is your means of being financially solvent, then you're going to fail, because the individuals are going to change jobs and they'll see through that. If you're in a hospital-based perfusion group, you actually, I think, and I spent 25 years in a hospital-based perfusion group, I think there's more challenges there, because it's very difficult when you have 3 or 4 individuals to become a group that can really find supporting measures to promote, the need for more individuals. We used to use the 135 cases a year as a value to shoot for, to have good work life. Well, that's crazy, because perfusionists are doing so much more today. 135 cases would be great if you're doing no ECMO, but add 1 or 2 ECMOs on a month in there, and that throws that value right out. So there's got to be a good way of negotiating and advocating for perfusionists. I think the outsourced perfusion providers, that are focused on that, really, at least in my experience, looking at the numbers that are out there, do a good job. And I think there could be some improvement in hospital-based groups, not the individual perfusionists, but the administrators, and listening to them.
Thank you. I have a question from Neil Casey. He says, hi, report suggests women suffer more with stress. Please comment on the fact that men die 3.5 times more than women by suicide. I have 2 former male colleagues that fell this way.
Oh my God, I'm sorry. I wasn't laughing. I didn't wait for the suicide. I was thinking, 3 or 4, 5 times more men die in general. And that's true. If you look at what we learned with COVID, having a double X chromosome is actually predictive. There's an immunological benefit that women have over men that really came to the forefront with COVID, since it was an immunogenetic condition that really caused those who are immunocompromised to suffer more, and men died 3 to 1 compared to women in COVID during that time period. Suicidal ideation, that's a really good point that the gentleman had brought up, because the causes of that are so significant, and a lot of it, and he's right, a lot of men tend to internalize their perhaps feeling of well-being, and not express that as well as women from an emotional perspective. And that's been proven, that's been shown. And then, therefore, once they get into an ultimately stressful environment, and this poor gentleman had known several colleagues who have passed away. My brother-in-law died from suicide as well. And it really is very disheartening, because you want to feel like from a male perspective, there's going to be an intervention, but a lot of times I think men perhaps don't reach out for those services. The one nice thing that occurred in the federal government just within the last 6 months was the suicide line. And we had a friend recently, we called that for them. And I tell you, the services that immediately occur by calling that federal number are impressive. I mean, we had probably a dozen people call us back and help us within hours. And thank God that individual ended up doing much better and didn't progress to a direction. But sorry, I don't want to go on about that. I think that's a very important point that the gentleman with the question made.
Thank you, Al, for just mentioning the resource line, because I was just going to ask, are there resources out there for individuals who may be experiencing a difficult time? And I know sometimes we do not want to be transparent with one another, what we're going through, but you may want to just talk to someone who's kind of like outside of your circle. So thank you for mentioning that.
Thank you, Bridget.
So this question has been up like several times. An anonymous attendee stated that there's another factor here, in that non-clinical people often dictate what clinicians do and don't do, such as administrators and insurance companies. So in your experience, you have so much experience in this field in many different roles. Is there anything that you might suggest on how to navigate those difficult situations?
Yeah, that's an excellent point. And getting back to the example that I said, that my last place of employment before I came to specialty care, I worked in a little community hospital. There were 2 perfusionists, 2 surgeons, 2 anesthesiologists. We saw the president of the hospital all the time in the lab, in the cafeteria. So everybody knew each other. But unfortunately, my work partner, her ID badge, she'd been there for 7 years, said percussionist, and it not perfusionist. And I asked her, when you saw that error, when you first had your badge made 7 years earlier, this is a true story. When you went to tell them it's a perfusionist, not a percussionist, the person who gave her the badge from HR said, "I just go with it. That's what we'll go." A true story. That is a true. I actually have the picture of it because I kept it. And I think that is important, because a small community hospital like that, perfusionists are considered advanced practitioners. I don't care what you look at, CRNAs, physician assistants, nurse practitioners. We may not order meds and drugs, but we are doing similar work, and it's very similar training. So if we would get identified at the hospital level in the advanced practitioner category, I think a lot more recognition would occur, and then administration would realize, just as they look after their advanced practitioners, they would have perfusionists to see as well. And I think that's a step that we should be moving towards, either by our professional societies or locally by getting more involved with that group of individuals who have been so prominent now over the last several years.
Thank you. I have another question here. This is thank you, Al. It has been missed. He wasn't here earlier, but he wanted to know, well, what is a solution for finding happiness in salary? I recently interviewed a young perfusionist and asked, how did you find perfusion? And the answer was, I Googled the highest paying non-job in hospital, MD job in the hospital. And he wants to know, well, what can be, how can that be resolved?
Yeah, that's a very good observation. And I think, a lot of people in leadership positions in perfusion probably have experienced something similar, and it's very tough. What's published on this, and I actually went over a few of the reports and surveys on this. What's published is if economic remuneration is your primary focus for happiness, that leads more often to anxiety and depression than if you have a more realistic expectation in regards to what your pay should be. It's scary to hear that, and it's a little bit frightening because individuals who are focusing on that, I think, have missed the importance of patient-directed focus on why to become a perfusionist. And again, I don't mean to talk like the old man on the call, but when I entered perfusion, my first job in the mid '80s was $13,000 a year is what I was paid, and that was a $2,000 increase over my research associate position, which I thought was good. And nowadays, as we move into a realm where the shortage has inflated salaries, maybe for the better, are we doing ourselves a disservice by not addressing the perfusion shortage in a more aggressive manner, so that perfusionists aren't looking, forced to, change jobs in, a major city from one hospital to another just for a few $1,000s more. So again, I'm not really giving a learned answer, but all I could say is that if somebody really did have that as the primary focus to enter perfusion, I would be very worried and hope that individual seeks some counsel from experienced perfusionists, perhaps who've been in the field, a few years longer.
Thanks, Al.
Absolutely.
Sure.
Tara Johnson asked us to mention live, and I think it's so important that as of July of 2022, the suicide hotline number, much like 911, is now 988, and it's also a crisis line. So thank you so much, Tara, for offering that up for us. And a good lead into that is Deborah Kobe asked, do you think that there should be perfusion support groups?
Yeah, Deborah, that's a really great point. And, we get a lot of that when we attend meetings. And look what happened the last 3 years. I mean, basically a lot of our meetings went virtual. And then, we're just starting to trickle back into on-site meetings, with CREF and the Academy and AMSAC. And the benefit of having that close interaction with our peers and colleagues, I think really can't be overemphasized. Zoom calls are okay, and they work well for a webinar such as this one, but they surely don't institute a feeling of companionship amongst our colleagues. We're all doing the same thing. We're all working very hard, maybe different environments. And it's not until you get that one-on-one relationship or the group relationship where I think you have the ability to go ahead and that peer interaction has been shown in research to really reduce stress and make a better work-life balance. So that's a very good point. One thing that I think you can do, and I've tried this throughout my career, and we've been successful at times, is having journal clubs. And we would have journal clubs, and we wouldn't just have perfusionists, we would have anesthesiologists and surgeons. All three of us would get together, it'd be off-site, off hours, and we usually had some cocktails and food, minor hors d'oeuvres and everything. And we would have an anesthesiologist present a journal, a surgeon, and a perfusionist, or a physician assistant and surgeon. and they were wonderful. They were just really great and conducive to that collaboration, that breaking the silo format. So Deborah, I think that's a very good point. And the greater interaction you can have, I think the healthier we would be.
Thank you, Al. Absolutely. I just, having a support group would be wonderful. And maybe that can be a survey that's sent out to the perfusionist. Would you like a support group within, your area, and maybe within the surrounding area, one can be created. Because when you talk about perfusion, no one understands but another perfusionist. No one understands, the details of what you do, or if something goes wrong and you want to bounce something off of someone else, you can only talk to a perfusionist. You can't talk to your spouse. You can't talk to your best friend. So you have to talk to someone who does what you do. So I think, possibly a survey for us would be fantastic, and who would want to, participate or volunteer in starting up a support group would be fantastic. Thank you. We have another question. It says, if 47% of the healthcare workers are going to leave their jobs by 2025, the stress level is going to increase. Has that been addressed on how we're going to replace, even perfusionists?
Yeah, that's a great observation that individual made. And it's so critical that the federal government has made this a top priority for healthcare workers. I mean, you're going to see a lot of money, just like the Affordable Care Act, poured billions in dollars in improving safety and reducing medical errors and patient harm. You're going to see the same thing occur, but now the focus is going to be on the healthcare provider. We already see that nursing programs are increasing enrollment. Look at the perfusion schools, perfusion education programs. It's hard to find a program that was in existence 10 years ago that hasn't increased their enrollment, some doubling their enrollment. And there's 5 or 6 new programs that have come out, starting with some of them at 10 or 12 students. The problem is going to be finding clinical sites, and that's what the nurses are running through right now. The nurses are having hard times finding preceptorships, and the same thing with perfusion schools. They're having hard times finding rotations for the students, working diligently at it. And there's been a lot of altruistic perfusionists who have volunteered. But you're exactly right. 47%. This is top priority by the federal government, and also at the state levels. A lot of states are looking at this and promoting nursing education programs, medical school increasing enrollment as well. So people are well aware of it, and it is being addressed.
Thanks, Al. We had an anonymous attendee ask, what can be done to address the fact that perfusionists are being given more ancillary tasks to perform, either pre, during, or post bypass, without any recognition, pay increases, or concern of overloading the individual to a point of patient safety concerns?
Yeah, these are absolutely phenomenal points that individuals are making. You remember how we would try to increase a technology, get something new in our pump, or a different heart-lung machine, whatever, a centrifugal pump versus a roller, whatever it was, doesn't matter. And if you went in and said, look, I can improve patient care, platelet reduction, you give less platelets, I want transfuse less, so, blah, blah, blah. Look at any of the variables, outcome indicators. Forget about it. If you want to make change in your practice right now, always go in and lead with safety. Safety, was identified, again, I keep on referring to the Affordable Care Act, but that was really generated by the Institute of Medicine monographs on first air, do no harm, crossing the quality chasm. I mean, that had tremendous changes in the healthcare system in this country. So if you're going in, and you're right, all these ancillary responsibilities that a perfusionist is being asked to do when they need to be focused, especially critically on when the patient is on bypass, lead with safety, and work with individuals. Bridget said, the support groups or academicians who are perfusionists, find the publications that have identified safety as a #1 critical area, and use that as a lead-in, because, you want to get somebody's attention in administration, come in and say, I'm afraid that, patient harm, risk management is going to get involved. Patient harm is going to ensue, and the risks here are greater than the value, and you will get responses. I guarantee it, more so than if you go in and say, I'll knock down transfusion rates by a half a unit of blood.
Absolutely, that's a fantastic point.
Thank you, Al.
Sure.
This question is from Maui Malunin. Are there any active surveys or research in progress to look into perfusion-specific stress, burnout, or job satisfaction? Because we noticed that a lot of the literature had been probably before COVID some time ago. Was there anything actively going on right now for perfusionists and looking at the burnout?
Yeah, that's a really great point. There are a couple of student research studies. They're mainly surveys that are being done, which you always have to be careful with surveys, but usually it's the best we have. A good place to look at this, though, again, is an outsourced perfusion provider, Comprehensive Care Services, a huge company. SpecialtyCare, perfusion.com. There's so many, and there's others. Keystone Perfusion. There's so many that are out there. The majority of them do exit surveys and talk about what the reason is that an individual will leave. And I would say the majority of those companies not only find out what the reasons are, but then respond to them. Because if you have a high turnover rate, you're not going to be providing patient care, meaning you're not going to be staying in business long. So listening to why people leave an organization is important as why people come into an organization. So that's one of the benefits, I think, of an outsourced perfusion provider. Before I went to work for one, nobody ever asked me when I left a job, why I was leaving. That just, in whether I was in a university setting or a community, they didn't really follow up on that. I don't think they really, I shouldn't say they cared. I'm sure they cared. They just, percussionist versus a perfusionist. They didn't know we existed. So that's one of the benefits. And that would be a good place if I was going to do a research project on it. I would be working with the HR departments in these large perfusion outsource providers to see if internal information can be found that to help others to improve working environment conditions.
That's great. So we have, I think, a few questions here that we can kind of merge into one. I know that we're coming close to the top of the hour here, but Kareem Jabbar said, should we have someone like Dr. Friday, a sociologist, psychologist, support perfusion around the country? He did a great job in the 80s. And another participant asked anonymously, should mental health screenings be administered at regular intervals to healthcare providers?
Yeah, those are both very good points by Kareem and the other individual. Having a sole source provider who understands the perfusion profession, as Paul Friday did, is a good idea. I mean, it unfortunately is very expensive, but I think it's a sound idea and something that should be looked at. And the professional societies, AMSAC, Kareem is on the board of director of AMSAC. I'm sure he has some more thoughts on this, and I'd love to hear his thoughts. Perhaps he could address this in a future webinar. As far as mental health, and I believe the question was on mental health evaluation as far as having a pre-evaluation of perfusion, not perfusion students, not people entering the field, but a mental health evaluation of practicing perfusionists. And that's really a very, very important point. And that's why one of the tenets of a successful intervention putting forth by the federal government was to empower leaders. It could be chief perfusionists, could be director of ORs, empower individuals, by receiving additional training in what the signs of depression, stress are. And just to finalize too, and specifically, I don't mean to sound sexist, but specifically working with women, who's been proven time and time again to suffer stress and burnout higher than their male colleagues. But thank you all for the questions. These are all very, very excellent points, and I learned a lot from everything that's been asked.
Awesome. Thank you, Al. I have another question here from Timothy Fortier. He says, after 33 years, I have more stress by EPIC than any other aspect of the job. Is there an answer to that, or how that can be improved?
Yeah, and Timothy, you're spot on, because if you search on the effects of a medical EMRs, remember these were done. The primary goal of this was to reduce the workload that's associated with clinicians. A lot of it was nursing and doctors, but perfusionists who are using Cerner or Epic, and even now the new data collection systems in the heart-lung machines, it's extremely stressful and taxing. And you know, there is a focus. I mean, I don't have an answer right now, but people are aware of this. If you search on the negative consequences of EMR EHRs, none on perfusion data collection systems yet, but I bet you they will be out soon. You'd find that these are real problems that are associated with the provision of care. So at least there's a direction. At least people are looking at that as saying, you know, this is a problem. We got to come up with a solution. Whatever that solution is, hopefully we'll see it sooner than later.
Yes. I know I was using Epic and I just completely got kicked off. And I could not get back in. And anesthesia had gotten kicked off as well. And so it's like you have to, you know, immediately transition into, okay, I need to document with paper, you know, so it's kind of like you have to be ready. It's not foolproof yet, but you have to have it in your back pocket that the old charting and how you used to do has to be readily available so that you can continue to document your case.
I think we're going to have a webinar. I will put that on our list to talk about the challenges associated with electronic health records, Epic center centricity, and what people are experiencing, because I am not a fan of specifically the Epic module for perfusion. I think that actually is going to set us back more than the systems that allow us to have registry data being entered in systems such as Perform and others, where Orem, I think, is a new one that's out there, where perfusionists can answer very specific questions by having more control of the data. So, and I think Epic is doing perfusion, my own opinion, a disservice. And I think these other systems that are out there are very beneficial to the perfusion community.
Thank you.
So I know we're a couple minutes over, Al, but do you have time for a few more?
Sure. I mean, and I know, you know, people, you know, can drop off at any time, but yeah, absolutely. If you know, whatever you feel, you guys are moderating, so whatever you think, I'll follow your lead.
Sure. This one has you know, several up likes, and I do think it's something that it is important. The Q&A box is just lighting up like a Christmas tree over here. So an anonymous attendee said, great presentation. It's a mostly taboo subject in our field, but I wanted to acknowledge another area of stress, which is microaggressions experienced by clinicians in the field, whether it's from within the perfusion department, from a surgeon, OR staff, or admin. It's just an additional layer of stress that happens, but people may not feel comfortable addressing it due to perception or fear of retaliation. An example would be the things that Vivian Thomas experienced. I just wanted to give voice to that. Thank you for your talk.
Yeah, that's another very, very valid point. You know, there's been a lot of gender inequities and that have been replied, you know, as far as ethnicity and race issues, you know, those are, you know, right up there too. Luckily, most hospitals are mandated by Joint Commission and other regulatory agencies to address this. And I think, you know, 20 years ago, individuals who were found in non-compliance of any of these issues related to race, creed, ethnicity, sex, you know, it was almost laughed at. And nowadays, any of these type of situations that develop that would tongue-in-cheek be laughed at from a sarcastic perspective are now addressed rapidly. So, you know, and again, I'd love to hear other people's thoughts, but I would imagine in my last years when I was practicing, you know, you didn't joke like that anymore. That was, you know, that was totally, and some of it was not joking, some of it was serious. And now I think it's thwarted, hopefully very quickly, because of the ramifications associated with perhaps even a reimbursement issue from federal funding, Medicare and Medicaid, if individuals are tolerating that behavior. And it makes front page news. You know, what hospital wants to make front page news with any of those conditions that are reported? So you're right. I think that was a very good point that individual made. Absolutely.
And just very quickly, it's something that I've been thinking about through this, but an anonymous attendee asked that we please give a shout out to the Women in Perfusion group on Facebook for female specific support, questions, and more. I myself am a member, and I've found it immensely helpful over the years. So,
amen.
Thank you. Wow. I just did not want to go over too much in time. Shannon, do you think that we need to continue?
I think it
Just
could
wanna
be, a part 2 webinar with the way that they just keep coming
Good
in.
idea.
So, I mean, we
Yes.
do eventually have to call it and maybe, compile some of these on a follow-up.
Yes, I agree. I agree. It was an excellent topic. Thank you so much, Al, for just opening everything up and encouraging everyone to actually put their questions that were in the back of their mind, but on the table, that we can actually talk freely about some of these topics that we are experiencing and how we can push through to have and maintain a work-life balance and have a healthier life, not just for ourselves, but for our family, because it goes both ways. You want to be healthy for your patients, but you want to be healthy, for your family as well. So thank you so much.
Thank you. Thanks very much, Bridget. And thank you, Shannon. I really do appreciate it. Did a great job of moderating. And I just want to thank all the participants. It's always great and to have individuals on. And as always, if anybody has an idea for a webinar, as Shannon and Bridget said, we can obviously do this. And if you have a presenter in mind, please just send us the name of the individual. I will reach out and personally invite them and then handle all the logistics. So thank you so much. Those are always great suggestions.
Thank you.
Thank you.